Welcome to tonight's webinar, Desiccation Shock Technology, a novel technology that boosts periodontal healing by eradicating all microorganisms in periodontal pockets. My name is Fazila Hassan Ali. I'm a registered dental hygienist and dental hygiene specialist for oral science for the region of Central Toronto and East GTA. It is my pleasure to welcome our speaker for tonight, Martha Shapolsky, registered dental hygienist and professional education leader for oral science. Martha is a professional educator and speaker who has been a practicing dental hygienist for 18 years. She has gained her experience through general and community dental practices, dental hygiene education, and mobile dental hygiene in long-term care. Her vision is to help clinicians create a synergy between evidence-based practice and common sense practicality that is uncomplicated and implementable. Before we begin, here are a few pointers. Please ask any questions in the question section of the webinar, and we will answer them at the end of the presentation. You will receive your certificate automatically a few days after the webinar, so you don't need to send an email requesting your certificate, but be sure to check your junk mail. And lastly, make sure your sound is on. Thank you again for your presence tonight, and we wish you a great evening with Martha.
Thank you very much, Fazila, for that lovely introduction. It is my pleasure to be with you guys this evening. Representing Oral Science, we now have 20 years as a company here in Canada, and we have in all that time been your dental hygiene specialist. And in 2024, we're really trying to have a new model where we're going to be helping our hygiene teams in 4 different pillars. We're going to be looking at categories like diagnostics and monitoring, in-office treatments, home care treatment, as well as team and patient education. Today, we are talking about HYBENX, advanced dental debridement and oral tissue decontaminant, and this fits in the pillar of in-office treatment. So I have a lot of material to cover with you guys this evening. I'm very excited to share it, so we're just going to get right into it here. First of all, let's talk about the objectives for the evening. We're going to start by reviewing our current methods for dealing with dysbiosis and periodontal disease in a hygiene appointment. And then I'm going to introduce HYBENX to you. And we're going to do a little bit of chemistry so you can learn about the mechanism of action. I'm going to talk a bit about the efficacy and safety of HYBENX. And then in the second part of the program, we're going to get down to the real practical points. I'm going to help you to know how you can select a client that would be good to use HYBENX. I'm going to go through a step-by-step application with you. We're going to talk about advantages of using HYBENX for you, a clinician. We're going to talk about the advantages it presents for your patient. I'm going to share with you an example of presenting HYBENX to your patient as a treatment plan option, and share how you could incorporate it into a care plan. And we're going to use the example of a localized periodontitis case. And then lastly, we're going to share how you can learn more about HYBENX through the oral science team. So let's first start talking a little bit about what we currently do in non-surgical periodontal therapy. Well, of course, as you guys know, our SRP is our gold standard, and I think airflow biofilm management has definitely elevated SRP to a new level as we're really trying to target biofilm. And of course, over the years, over the decades, we have come up with several different adjuncts to our mechanical debridement because we recognize that mechanical debridement can sometimes be incomplete. They tried SRP with systemic antibiotics, and as you probably know, this rarely works because systemic antibiotics cannot really penetrate a biofilm, so long-term benefits are really not there. You also have SRP with localized antibiotics. This is another option that can work well in some instances. We have SRP with periostat, which is a fantastic option as you have the mechanical debridement for local inflammation, and periostat is treating the host response. And then we also have SRP with lasers, another good option as it helps to really get rid of any sort of dysbiotic biofilm. But there are challenges with all of these methods. When we talk about doing SRP alone for a periodontal patient, generally we find that hygienists are effective and it is generally quite easy to work up into a 3mm pocket. However, once we advance past that 3mm and the deeper it gets, it becomes more challenging, and studies show that even experienced clinicians have difficulty removing all of the biofilm and even sometimes all of those calculus deposits as the pockets advance. And finally, when you're doing SRP alone, what we're trying to do is do as much removal as we can and then disrupting the remainder. And we're relying on that immune system to clear that microscopic debris and toxins. We have a lot of hurdles as we go through this. Calculus can be tenacious, roots can be irregular. We can have difficulty getting access into deep pockets because of the limitations of getting our tools into a non-surgical area and even embedded into toxins in root structure. And when we consider SRP plus a localized adjunct, there can be also some limitations there. There can be the cost. Something like laser is not a cheap machine to buy, right? Or the post-op can be complicated. Sometimes the pocket indication or selection, we're often waiting until pockets are established, which seems to be a little bit behind the 8 ball, if you ask me. And no antibiotic targets all the microbes in a pocket. And then we have the whole concept of uncultivatable bacteria. What this is essentially that in the oral cavity, we have many, many different microorganisms, and only a small selection of them are going to actually grow in a laboratory situation, grow on a petri dish so that we can study them, see how they act, see how they interact. So the vast majority of the oral microbiome is uncultivatable, so we really don't even understand it. So trying to specifically target specific organisms with like antibiotics, it's not going to be generally the best way to do it. And in general, I think we do underutilize our adjuncts because we find that sometimes they can be unreliable. So where does that leave us? Well, we're working through the merry-go-round that starts with dysbiotic flora, which gets us into inflammation that is like triggered by that flora, leads us into periodontal destruction. The periodontal destruction gets us into deeper pockets and more clinical attachment loss, which makes for more challenging removal of biofilm, which leads to more dysbiotic flora. And around we go, and we're doing our best. And sometimes we can be very successful. In other cases, it's very challenging and we don't have that success. So what I'm suggesting is we need something that takes us off the merry-go-round, and that is to completely remove the dysbiotic flora. And for a long time, most of hygiene, we really haven't had a way to do that. This is where HYBENX comes in. HYBENX is an in-office adjunct to scaling and root planing. When you're using HYBENX in conjunction with your scaling and root planing, you are actually going to have a complete removal of biofilm and bacteria. And if you have a dysbiotic pocket, you are going to be eliminating the dysbiosis in the pocket. This is going to have the effect of halting the inflammatory process. We're going to stop that process that leads to increased bleeding, clinical attachment loss, and increased probe depths. And we can even have potential systemic benefits because we are halting the inflammatory process in the oral cavity. This will lead down the staircase to biofilm removal that is easier for you as a clinician and also easier for the patient at home. They're not going to be dealing with those tenacious deposits that are very difficult to remove, but rather a more commensal flora. That's what we'll be repopulating in the area, and ultimately that gives you more predictable outcomes. So let me show you what it looks like. This is what it looks like. HYBENX comes in syringes. It comes in a gel formation and a liquid formation. It comes in a pack of 2. One syringe will basically be able to do a whole arch for you. So a little bit goes a very long way. And we recommend the gel formulation for periodontal applications. You can select to do the liquid, but obviously it's more runny. We like the gel formulation because it stays put where we put it. And HYBENX is a non-antibiotic product. So we're going to be helping to arrest that advancement of periodontal disease by actually eliminating harmful bacteria on contact without an antibiotic. If I have you intrigued, let's get to the science so I can explain to you how it works. So think about life, all life on Earth, whether you're a tiny bacterium or a gigantic mammal, we all need water. Liquid water constitutes about half the volume of every living biological cell. And water is actually 90% of biofilm. So what happened is the scientists that were working on HYBENX, they were saying we need to find a way to try to kill biofilm, bacteria, and basically said to themselves, what if we found a way just to suck all the water out of this pathogen source so that it just dies? And so this is what happened. They started to work with physical chemistry and they said, okay, there are forces that can actually suck water out of molecules. We have to provide that force. And HYBENX gel is that force? When you think about it from the scientific perspective, water is polar and it has positively charged and negatively charged sides, and those can be pulled by complementary charges. So what happens is you put HYBENX in a location like, say, a periodontal pocket, and it actually has a very strong electrostatic charge, and it can actually draw the water out of your pathogen molecules. And when you draw the water out of those pathogen molecules, they collapse, and you have a complete desiccation of biofilm, bacteria, and necrotized tissue. What you're left with is a denatured tissue coagulum. And denatured tissue essentially just means the proteins that were functioning to do the functions of the cell no longer work. So basically, we have a process where you're going to render all that pathogenic material completely innocuous. It's going to become detached from the root structure and easily removable. So rather than our current SRP model, where we try to do our best to do a complete removal, but we just can't get it in those deepest pockets, in those furcations, rather than doing that partial removal and disruption, we are actually going to be doing now a full removal of that dysbiotic biofilm, the inflammatory infiltrate and bacteria that are in the pocket. It happens in 10 to 30 seconds. That is the contact time we recommend for HYBENX in the pocket. Then you just rinse it away. And so we are left with a pocket that has no bacteria in it anymore. I'm going to show you a quick slide here of what HYBENX looks like under a scanning electron microscope. So the before pictures are on the left. You can see that this root structure is covered by a dense biofilm. The images on the right are after a 30-second application of HYBENX. And what you're observing is that the biofilm has now become compressed. It's become compressed and thinned because all of the water has been sucked out of it. And you can see it's lifted away from the root structure, which we like to call the peeled paint effect. This is part of the reason why HYBENX is easy to remove that biofilm. The active ingredients in HYBENX are something called sulfonated phenols. These are purified, pharmaceutical grade, sulfonated aromatic compounds. And I'm going to share a little bit more about those in just a sec. What it does, it is a chemical desiccant and an enhanced mechanical rinse. So it is a chemical desiccant that safely removes the microbes and tissue debris from the treatment areas without impacting other areas of the human microbiome. And it does this, again, how I said, by that electrostatic charge. It's stronger from the water to be drawn over to the HYBENX than it is actually in the bacterial cells. And that's how we pull all that water out, and it's nice and at a clean pocket. And then what happens is you actually have an enhanced rinse as well. It's going to remove all that denatured coagulum. The process altogether is called desiccation shock technology. I'm going to enhance a little bit here about the mechanical rinsing to help you understand why it's considered enhanced. When the HYBENX goes into a pocket, it is actually 1,400 times the viscosity of water. That is at room temperature. You put it into the pocket, it sits for that 10 to 30 seconds, it warms up to body temperature, and then it becomes actually 400 times the viscosity of water. So this actually makes it much easier to rinse. So this is an enhanced mechanical rinse because, first of all, number one, when you are actually putting it into a pocket, it has enough viscosity and density so that it can force its way into all the little crevices that are in and around a root structure. But when it comes time to rinse it out, it has decreased its viscosity, so it's easier for you to remove. Now, when you get a package of HYBENX, you're going to look across the active ingredient list and you're going to say to yourself, wow, there's some acids in here. Is HYBENX acidic? Well, the answer is HYBENX is not acidic. Basically, this is how it works, and this is a little bit of chemical science. When you have concentrated acid products like HYBENX, you cannot measure or even apply the concept of pH because they are not sufficiently dilute that the acid proton can be considered to be able to freely separate from the acid ion for a lack of free water. In physical chemistry texts, this property is typically expressed as highly concentrated acids are not acidic. So essentially, you have to remember that a strong acid and a concentrated acid are not interchangeable terms. And when we think about things that are acidic, what we are thinking of is strong acids. They have pH. The hydrogen ions have become freely dissociated or ionized in the solution. And because it has those free-floating hydrogen ions, it is a strong acid. A concentrated acid, on the other side, has no ionized hydrogen ions. They are all bound to the chemical structure they were in there. And because they are not actually dissociating at all, they have no pH. So when you talk about things like this, HYBENX is acids, but they are not acidic. If that at all twists your mind around, just head on to Google. I did, and I watched some chemistry videos, and I got the concept in my head. So let's talk about the effects in the oral cavity. So first of all, biofilm, bacteria, and necrotic tissues. HYBENX is going to desiccate the biofilm, it's going to denature it, and you'll be able to rinse it away completely. When they started to work with human studies, they had a huge side bonus when they came to calculus, because it turns out that HYBENX can soften calculus when you apply it pre-debridement. For the healthy soft tissue, what you will observe as a clinician is that there's going to be some temporary blanching of the tissues, and that's due to a reversible desiccation. In essence, HYBENX does not harm healthy tissue. HYBENX is actually selective to biofilm and necrotic tissues since they more readily give up their water as compared to the healthy tissues around them. So that's how it works. It's actually selective, and it turns out that the water is given up more easily by those biofilms, bacteriums, and necrotic tissues than healthy human tissue. When it comes to restorations and implants, remember, HYBENX is not acidic, so it can't actually etch them. So restorations and implants, there's no effect. And also restorations and implants have no water to donate to the HYBENX, so there's no effect there either. Hard tissues, your dentin and enamel, there is a weak effect. Let me share a little bit more about that. They did a lot of studies to make sure that HYBENX was a product that was safe for humans' usage. And one of the many studies that they did was checking an exposure on enamel and dentin. This particular one I'm sharing with you is taking a look at the calcium ion release from enamel surfaces. And they compared a 2-minute exposure of HYBENX to a 2-minute exposure of citric acid at the same concentration as orange juice and lactic acid at the same concentration you would find in yogurt. And indeed, the citric acid and lactic acids had a greater calcium ion release from the enamel surface in comparison to HYBENX. So yeah, having that exposure to HYBENX for your patient, they get more exposure to calcium ion release from the enamel if they had a glass of orange juice or if they had a bowl of yogurt. Now you may be thinking to yourself, this sounds amazing. It's removing all the bacteria. So what's it doing with the commensal flora? Well, when you apply it into a pocket, yeah, it's going to take out everything. All the biofilm and all the flora will be desiccated, denatured, and form that coagulum and rinse away. The really cool thing is that commensal flora repopulates in 24 hours. So, and remember, we're not actually putting HYBENX everywhere. We're only putting it in areas where dysbiosis is present, where we want to remove this community of bacteria that could be a combination of pathogenic and commensal floras that end up having a net effect of pathogenicity. So let's just remember that as well. So it's a really cool effect. Now I'm going to share with you also a randomized controlled trial that was done with HYBENX, and this was in patients with chronic perio. It was a split mouth design, and they followed the patients for 1 year. And basically they had one quadrant that they did SRP alone and one quadrant that they did SRP plus HYBENX. And so when they compared the two quadrants, they found in the SRP plus HYBENX group, there was significant improvements compared to that SRP alone in probe depths, clinical attachment levels, bleeding on probing, red complex bacteria, and also the level of inflammatory mediators. So they really tried to look at all the things that you could find in a pocket. What is going to tell us whether disease is arrested or not? And they just found that in both groups, obviously SRP also was helpful. but it was definitely significant improvements compared to SRP alone when they had the patients use the HYBENX. So there was one particular outcome that I thought was really cool, and that's the one I'm going to share with you. And it's a little bit to talk about red complex bacteria. Now, just to review, when we're talking about bacterial species, they have these sort of different color designations, if you remember back to your microbiology courses. And all of the colors at the base of the pyramid, yellow, green, purple, and the actinomyces species in the blue, those are all the early colonizers of a sub-G pocket. And then the orange pathogens come along. Those ones are starting to become your gram-negative anaerobes. They're going to be starting to have some effects of periodontitis. And then at the tippy top of the pyramid, we have your red complex bacteria. And these bacteria are closely associated with periodontal destruction and include our arch nemesis, Porphyromonas gingivalis. So red complex bacteria, very bad. We know there's going to be destruction occurring in pockets that have this bacterium present. Now I'm going to show you a little bit of a complicated chart, but I'm going to walk you through it here. If you look across the top, you see the timeline. So you have baseline numbers, 15 days, 30, 60, 180, and 365 days. Down the left-hand side, you see all the species of the bacteria that they studied. And on the right hand, you can see the different groupings that they have of all those ones that we saw in the pyramid. Now I'm going to draw your attention, first of all, to the top. So this is your actinomyces, the purple, yellow, green. These are those early colonizers. And what you'll see is the blue line is SRP plus HYBENX, and the red line is SRP alone. And what you see is actually it's a very similar distribution. So that I think is a good sign because it tells me that using HYBENX, it doesn't really affect those early colonizers. They repopulate, they come back, and that we can see those effects for over the course of a year. Now let's look at the bottom of the screen and take a look at the red complex bacteria. So if you look at the baseline at the left-hand side, we can see that the two groups were equal. When we go to 15 days, you can see that the blue line, the SRP plus HYBENX, is quite low. And then the SRP alone, it looks like at about a 50% decrease. Then we go to 30 days. You can see it's harboring at around the same 50% decrease in that red complex in the SRP alone, but the SRP plus HYBENX is completely flatlined. There is no red complex bacteria in there. Going forward to 60 days and 180 days, you can see in the SRP group that we're getting that increase in the red complex bacteria, whereas still no new growth of red complex bacteria for the SRP plus HYBENX group. And lastly, 1 year later, you can see that the SRP group, yeah, they're back to the regular numbers. And we're starting to get a slow regrowth now of those red complex bacteria in SRP plus HYBENX. So this really shows to me the power of using something that completely removes the dysbiotic biofilm. It takes it a long time to repopulate. It doesn't come back just like that if we're able to fully remove it. And when you compare it to SRP alone, you can understand why we need to see our perio patients every 3 months, because it's somewhere in that range after 30 days that things really start to accelerate, or after 60 days, it gets really, there's a lot of red pathogens in there. We have to get them back down again. So this is how we can make our SRP so much more effective by adding HYBENX. Let's talk about some tips and things. When you're using HYBENX, remember I mentioned there's going to be some tissue blanching with that healthy tissue. This is temporary. It's going to be 1 to several hours. It depends on how long you've left the product on there. 10 seconds will be less blanching, 30 seconds a bit more blanching. You're going to also notice hemostasis in the area, which is very helpful pre-debridement. The product may elicit during contact until it's rinsed off, those 10 to 30 seconds, maybe no sensation. There could be a bit of a tingling sensation, and in super highly inflamed tissue, it's possible that it might feel a little bit like a sting. So this is basically a way for you to think about if they're highly inflamed, if you know that that debridement would be sensitive and you would already be doing LA for that patient, make sure you do the LA before we do the HYBENX therapy. Also, the taste of the HYBENX is a little bit sour. So we like to really maintain a good isolation so that number one, the area stays dry, and number two, that the patients don't taste that sour taste. And I also recommend that it's a good idea to manage your patient expectations with some good communication. If this is a case where a patient has a lot of swelling, like maybe it's an initial therapy, you can see the tissues are bulbous and everything. If you did a definitive debridement for them, you would notice right away that there would be some tissue shrinkage afterwards. And that effect will also occur with SRP plus HYBENX. So you want to make sure a patient is aware and that they manage their expectations and they understand that there's going to be spaces maybe now in between their teeth and they're going to feel that difference, but this is a healthier tissue. When not to apply, let's talk a little bit about contraindications. So specific contraindications, it's not for patients allergic to a material that contains sulfurs in any form. That is different from sulfonamide drugs, aka sulfa drugs. There's no cross allergy there. So HYBENX is okay for patients with a sulfa drug allergy. We also don't recommend it for patients that are under 18 or for pregnant patients. It's because we've had no studies for these patient groups. So out of an abundance of caution, it's not recommended at this time. And in dental applications, like a root canal therapy, it's not to be used with calcium hydroxide. For when not to apply for situations, well, it's when the tissue is healthy. If there's an absence of inflammation and dysbiotic bacteria, there's no need to apply HYBENX there. And I would also suggest, in my opinion, that I would probably say for very mild cases that I know are going to predictably respond to conventional SRP and OHI, I would try that first and make sure things respond. And then perhaps if something is non-responsive in the future, I would definitely consider applying HYBENX. So the indications, it's whenever you as a clinician observe sites or a site that have either dysbiotic biofilm accompanied by inflamed or swollen tissues, if there's heavy bleeding present, if there's exudate present, if there's calculus present. HYBENX can help with all of these different situations. Where and when can you apply it? It can be applied supra-G and it can be applied sub-G as well. You can do it in a site-specific manner. Say maybe there's just one or two places that you think are dysbiotic and unresponsive, or perhaps in an initial therapy, this patient may need to have their full mouth done with the HYBENX to get rid of that dysbiotic flora. You can apply it around natural teeth and you can apply it around implants. It's a great idea to apply it in areas where your SRP access is limited, such as a furcation or very deep pockets. As I mentioned, initial therapy, or perhaps when you have a patient of record and the conventional SRP is not providing optimal results. It can also be used in a non-periodontitis type of an aspect to actually seal and protect open ulcerations, such as aphthous ulcers. I remind you that HYBENX is actually not tied to a specific diagnosis. So it's not just for periodontitis. It's any time that you see dysbiosis or inflammation, and in your professional judgment, you believe that removing the dysbiosis in this situation is going to give improvements. That could be in gingivitis, periodontitis, peri-implant mucositis, peri-implantitis, or even in oral lesions. And for dentists, they can actually also use it for endodontic cleansing and even smear layer removal before bonding procedures or perhaps before cementations. For periodontitis, removing the dysbiotic flora is going to be much more dramatic in patients that have a severe periodontitis. Because remember, they're going to have, if they have severe periodontitis, an abundance of red complex bacteria. And as you saw in the study, if we can get rid of them, you're going to see really dramatic results and speedier healing. So let's take a look at the product now. We're going to kind of walk through what it looks like so you can see for yourself. So very standard syringe like you've used with other products. The cap is recappable, so if you don't use it all, you can save it for a second appointment with your patient. It comes with two different syringe tips. The big blue one, this would be for probably your supragingival applications because it's quite a robust one. And then the clear tip is for your sub-G applications or for a very site-specific area, maybe like a narrow vertical defect or something like that. It's going to help you to get into those. So you choose the tip that's going to work best for you, but those are the general guidelines. Step number 1, you're going to do your site selection. So this could be like, say, in a case like this would be an initial therapy. Clearly, we see that that lower anterior sextant has heavy calculus and dysbiosis. We see the inflammation, the tissue has changed its contours. So this is an area that would be a good selection for HYBENX. Now, also, I just want to give you a couple tips. When you're also assessing your patient, think about, do they have any likelihood with general SRP? Would they be maybe sensitive, like have dental hypersensitivity, or would they have soft tissue sensitivity? Because if you think they would, then I would suggest either applying crystal or Desiccation or a local anesthetic. That would be relevant to the patient case. And as a tip from people that are already using the product, they say that on virgin calculus that hasn't been touched by a scaler, it desiccates really, really well. But burnished calculus, it doesn't desiccate as well unless you roughen it up. So you can get in there with a file or some other instrument, try to roughen the surface outer layer of that calculus, and then get the HYBENX in there, and it's going to actually soften it up so it becomes easier to remove. All right, step number 2, we're going to isolate and dry the area. You can do as simple as a cotton roll isolation for sextant 5, as pictured here. Once the area is isolated and dry, we're going to apply HYBENX for 10 to 30 seconds. So we're going to be putting this maybe on the calculus. I'm doing this on my little typodont here for you guys today. And because it is a super gingival application, I've elected to use the big blue tip because it's going to be faster application. I'm going to make the decision that I want to apply it to the lingual side first because there's more calculus there. So I want to have more contact time on the denser calculus and maybe less contact time on the facial where the calculus is less dense and mostly interproximal. So think about it. If you're doing this pre-treatment application of HYBENX, it's here to ease the treatment. It's going to make calculus softer. It's going to have a hemostatic effect. So people are definitely choosing to do this in the presence of big calculus deposits. And if the tissue is very, very inflamed, you may like it because you're going to enjoy that hemostatic effect. Ultimately, though, if there's not a lot of calculus and the bleeding is not profuse and you don't think it's going to impinge into your debridement, you may choose not to do the pre-debridement HYBENX application. So it's optional. You can do 2 applications, one before and one after, or you can just do 1 application just afterwards. So that's what that looks like, the HYBENX application. Then once it's applied, it's had its 10 to 30 seconds on the teeth, you are going to do a very good rinse. You're going to get in there with your HVE, suck off like the excess, and then use your triplex syringe with water and do a complete and thorough removal. As you can see, the product has this purplish color. When it comes in contact with biofilms, it sort of turns like a brownish color. That's normal too, but you're going to just rinse it all away. Do a very thorough rinse. Remove your isolation, make sure nothing got sloppy, make sure there's no HYBENX anywhere in the vestibules or anything. Just do a really thorough rinse. Then you're going to do your debridement. That can be with your ultrasonics, that can be hand debridement, whatever you do it as you do it, customize it to your patient treatment. Then you're going to do the post-debridement HYBENX. So this is sub G. This is going to be going into the pocket. So now I'm going to select the clear tip. The clear tip is going to have that nice fine tip that it can get all the way down. The goal of the post-treatment application is to do that complete oral tissue decontamination, to remove all of the dysbiotic biofilm and all of the crevices everywhere there is. I thought I'd do for fun with you guys, I'd do like the furcation on the 6 for this one, just something a little bit different. This is going in where we can't remove all of that dysbiotic film mechanically with our instruments. And when you're applying it sub G, what you do is you insert it just a little bit under there. You're going to allow the material to flow into the pocket. And when it comes up above that cervical margin, then you stop and you know that it's in there. Obviously, after that 10 to 30 seconds, once again, a complete rinse with your tri-syringe and HBE. And then after HYBENX with SRP, this is what you'll observe. You've had easier cleaning. You know the dysbiotic flora is not present anymore. And you can observe on these images how there is that blanching of the tissues. Again, this is temporary. That's the healthy tissues. They blanch, but then the blanching is due to a reversible desiccation. They get water back into them and they start to become back to normal color within an hour to a few hours. I'm going to share with you one case that I thought was really neat. This was a case study that was published. It was the treatment of an acute periodontal abscess using HYBENX. So these pictures are viewing from the lingual side of quad 2. You can see that there's this acute periodontal abscess distal to the 2.7, and between the 2.7 and 2.8 there was abscess with pus, swelling, bleeding on probing. They measured 15 millimeters at the maxillary left second molar. Severe bone loss revealed in the periapical radiograph. So what they decided to do in this particular case is they actually didn't do any instrumentation and they didn't use local anesthesia. They just used HYBENX. They placed it in there, they rinsed it out, and then they did not prescribe any systemic antibiotics for this swelling and abscess. What happened is after about 4 days, the patient had already improved conditions around there because that was an area of pain for him before he went in for the appointment. They had him back in the office at the 8-day mark, and you can see that the inflammation, swelling, and pain had completely disappeared, and there was a marked reduction in the probing depths. They're measuring it at 5. And then at the 30-day mark, they actually looked at the treated area and it showed reduced pocket depth around 3 millimeters and an absence of bleeding on probing. An absolutely phenomenal tissue resolution in an area that is usually exceptionally challenging to treat. So a few things I would mention with this one is that when you actually read the case study, if you are going to go into it and take a look, you'll notice that this patient did say that when the HYBENX was applied, it was sensitive for him during that time it was applied. So even though they use no local anesthesia in this one, this is definitely a case where I personally would recommend to the patient that they should have a little bit of LA for their comfort so that it doesn't sting at all. And I just was like, this is quite amazing. There's more case studies that you can find on the Oral Science website. It has a link to the HYBENX website as well, so you can learn more about the studies that have been around this product. But I just wanted to show you how it can look. And I thought this one was neat because they didn't actually start with mechanical debridement. In the notes of the case study, they actually talked about how they did mechanical debridement once the area had resolved. They did just conventional periodontal therapy. So if you're thinking about concerns that your patient may experience that stinging sensation, if it's very inflamed and things, well, whether it's hard or soft tissue sensitivity that could occur, just like for scaling and root planing without HYBENX, you always inform the patient that this is a potential transient side effect. If you think it's appropriate, use Desiccation or LA before application. And it seems in the literature and anecdotally that sensitivity is most likely in areas that are very highly inflamed or a lot of hemorrhaging, just like that one I showed you there. You can also recommend Tylenol or Advil as necessary before and up to 48 hours after. 48 hours, I just say because that's typically the maximum time that people so far have said if they have soft tissue sensitivity, that's how long it might persist. You can also use vitamin E oil, you can also use ginger gel, anything to soothe it. And then for hard tissue sensitivity, I do recommend using crystal desensitizer pre and post, just like you would a conventional SRP appointment, and advising them to use a desensitizing toothpaste like Riemann, which can occlude the tubules with hydroxyapatite. All right, let's get practical here. Why should you use HYBENX? Well, the patient advantages is they are going to have a faster and less onerous appointment with less water, less lateral forces. You really have no need, even though we know we're not supposed to, but there's really no need for any aggressive root planing when you're using a product like HYBENX. And number two, it's giving that patient a clean slate in an area that has been dysbiotic, and it gets repopulated with commensal flora, which ultimately makes it easier to clean. It's a non-systemic therapy. You're not adding any more appointments. In fact, it might be less appointments if the SRP becomes less challenging. And they don't have any like fancy post-op instructions after HYBENX. It would be the same as your regular SRP appointment. They can eat and drink, they can do their oral hygiene right away. It's all good. And ultimately, doing this as part of non-surgical periodontal therapy, the cost-benefit analysis in their favor because HYBENX is much less expensive than periodontal therapy and even local antibiotic therapies. As a clinician, the advantages to you is having that more efficient debridement, which is over time, it's going to reduce your risk of musculoskeletal injuries and fatigue. You can also help to reduce potential bacteremia. I think this could be an amazing way to help keep perio patients in your practice if you're a GP. Maybe you work in an area, it's remote, there's no periodontist, or you have a patient who can't afford the periodontist, or they just straight up decline the referral. They're concerned about seeing a specialist. This is another way you can help them. For your insurance-driven patients, it can help you to stay in those SRP limits. And this is great if you've had that patient that you've been seeing for years, and why won't that 1-7 distal stop bleeding? This is that patient that they could have that, they don't have that tissue resolution that you want from your conventional therapy. This could be the ticket to get it to resolve. Obviously use it in those difficult access areas. I think the mechanism of action is easy to explain to a patient. I would just say, this is going to dry out all the bacteria and all the plaque inside that pocket that contains harmful bacteria so it can repopulate with healthy bacteria, which will make it healthier, less inflamed, and easier to clean. You're not really changing your treatment plan very much. It's just enhancing the therapy you already provide. And it's also an antibiotic-free option for patients who wish to avoid antibiotics. If you are working in a periocentric office like a periodontal specialist, you can certainly take a look at this chart for comparing HYBENX to, say, like locally applied antibiotics. It's less expensive. The indications to use HYBENX are more variable than just the periodontal pockets. It's going to be targeting all the periodontal pathogens in 10 to 30 seconds, whereas antibiotics take a long time to take effect. Antibiotics have no effect on your debridement effort, whereas HYBENX can make it easier for you. The post-op instructions for HYBENX are none or minimal. Sometimes the post-op instructions for locally applied antibiotics can be a bit more complex. I think the ease of application is there with HYBENX. It's easy to apply. You have multiple syringe tips that have flexibility and an easy rinse. You're actually physically removing all of the toxins that are in the pocket, not just bacteria. And then when it comes to contraindications, again, HYBENX, we're not going to want to have it with those people that can have a sulfur allergy, which is exceptionally rare, or with the locally applied antibiotics. Obviously, you want to make sure you're not applying it to somebody with an allergy or some of the various health conditions that are contraindicated by those kind of medications. A quick sample case for you guys. If you were doing a sample case presentation to a patient, say with localized stage 3 grade B periodontitis, number one option we could say is no therapy, which we don't recommend. Second option would be SRP alone, and then we reevaluate. And you can say this is our gold standard, but it does have its limitations, which you could share dependent on the case. Then you could recommend initial therapy of SRP plus HYBENX and evaluate. And explain to them how this is a cost-efficient way to non-surgically enhance the SRP gold standard and predictably remove all biofilm from a pocket and provide that patient with a new start. Now, monitoring and patient oral hygiene are still key. We've cleaned the pocket, but obviously after that, the body takes care of things and the initial flora that populates is commensal, but we're going to continue to watch and see what happens. Or they can head straight to that periodontist. That's option 4. So that's a way that you could actually have a sample case presentation to your patient. A sample treatment plan, that same patient, we're going to imagine that you have identified perio is in the upper molars. Other areas there's gingivitis, it's kind of severe, so you think that HYBENX would be a good treatment plan for this patient. So it would look like a little like this. Appointment 1, you're going to do your diagnostics like probing, radiographs. You're going to make your dental hygiene diagnosis. You're going to explain those treatment plan options to the patient. They're going to consent to a proposed treatment plan, hopefully number 3, which is with HYBENX. In that appointment time, let's say we have enough time, we're going to do our quad for debridement with HYBENX where we need it, and we're going to utilize crystal for that pre-op exposed roots because we've also noted the patient has some recession and occasional dentinal hypersensitivity. Appointment 2, we reassess quad 4, then we're going to go to quad 3. We're going to assess and see if they need any Desiccation, use as necessary. We're going to do that quad 3 debridement with HYBENX, and again, that crystal desensitizer pre-op. Appointment 3, we're reassessing the mandibular. We've elected to use LA for those maxillary molars because the patient had a lot of sensitivity on probing and you detected calculus. Then you're going to complete that debridement, say for quad 1 and 2 with HYBENX. Last appointment is in that 4 to 6 week reeval. You would reassess your BOP and probe depths, check on their OH, check your debridement, refine as necessary, and set your hygiene interval. So that is sort of a sample of how things would roll out, how it could look. This is a treatment plan for a new patient. So that's why it's multiple appointments. We're doing all that sort of stuff. Well, if you had a patient of record, it would look slightly different, but really it's just adding it into your treatment plan as necessary where you observe a dysbiotic biofilm or unresponsive tissues. So the last question people often have is, how often will I reapply HYBENX? And I hate to do this to you, but the answer is that it really just depends. There's a lot of factors that go into when the commensal flora is going to change and become dysbiotic. When would we have to reapply? That could be partially from the host response, maybe their level of oral hygiene, how frequently they're seeing you for professional debridements, maybe their systemic health is a factor in how they respond to the bacteria in their mouth. So, or maybe the HYBENX placement was incomplete or something like that. So it's really going to depend how often you would have to apply it. However, remembering to that randomized controlled trial I showed you with the red complex bacteria, remember that we saw that those red complex bacteria didn't regrow until somewhere between 6 months and a year, probably closer to a year. Whereas the control group of SRP had that red complex regrow in about 2 to 3 months. So my suggestion to you is that I think it's possible that if you have a patient with good oral self-care, and they're in good health, HYBENX may be a one-time treatment because once we've got the dysbiotic flora gone, they're able to maintain it, they have good oral health, maybe that's all they need. But then, however, if you have patients with compromised health and or compromised oral self-care, maybe we do need to reapply. It might be every 6 months. It could be a year. It could be every year and a half, every 2 years. It's going to be based on the results of your diagnostic procedures, primarily things like BOP and probe depths and signs of inflammation. It's not a systemic therapy. It's not an antibiotic therapy. All it's doing is local desiccation in a pocket. So there is no, it can only be done once a year. It's really dependent on what's happening inside the mouth. All right, so we've come to the hour, 60 minutes on the nose on my counter here, and we've come to the end of the presentation.
Thank you, Martha. That was a really great presentation. We've actually received some questions this evening, and we're going to try and get to as many as possible. But before we get to them, I'd like you all to pull out your cell phones to scan the QR code on your screen. It's going to direct you to the request a virtual or in-person meeting with your oral science partner to learn more about HYBENX. Our team of registered dental hygienists at Oral Science look forward to supporting you with the integration of HYBENX for your patients with areas of dysbiosis. Okay, so let's take a look at some of the questions. Are you ready, Martha?
I'm ready.
Okay, so one of them is it contraindicated with patients with a sulfate or sulfite allergies?
It is possible that people that have sulfate or sulfite allergies are going to have more of like a stinging response or possibly an allergic response. Now, my understanding is that sulfate allergies are exceptionally rare. Sulfates are throughout our entire world, everything from Epsom salts to supplements and things like that. So people will generally know if they have a true sulfate allergy. And the same is true of sulfites. Those are slightly more common than a sulfate allergy, and people will generally know when they have one. If it is a sensitivity, it may not be a true contraindication, but a true allergy, I think it would be contraindicated.
Okay, that's great. If someone has guided biofilm therapy in their appointment, GBT, would this be redundant? How does that fit in?
No, it doesn't. And I'm going to try to give you the short answer. And if you are working in a GBT office, I really strongly recommend you to get that QR code and get your oral science team member into the office to help you with the GBT cycle. Essentially, we do think that when you're doing airflow and perial flow, those do a phenomenal job with biofilm removal. However, because of limitations of how far you can get it into areas and everything, it may not be complete. So I would suggest if you're going to be incorporating HYBENX into a GBT appointment, it would come probably at some point after the PA's-on and your hand instrumentation as that final decontamination. So typically in a GBT appointment, we wouldn't usually apply it twice unless you saw substantial calculus that you wanted to soften. And if you were going to apply it, you would apply it at least after the perioflow step. And if you're going to only apply it once because there's not substantial calculus, you're just using it for decontamination, then you would apply it after your PA's-on and hand scaling.
Okay. Okay, how does it stop water from the gingiva from being sucked in and desiccated as well?
Healthy gingiva, it comes down to the physical chemistry of it. It does not readily give up its water as readily as biofilm and bacteria. So what you observe is a temporary surface desiccation, but it's able to rehydrate very rapidly. Whereas the HYBENX is selective and it can pull the water right out of bacteria and biofilm because it readily gives it up in comparison to the HYBENX.
Okay, someone asked if it affects enamel a little. What about cementum?
I would have to double check on the studies. I don't have the statistics off the top of my head, but it is, again, just that very mild effect, milder than orange juice or yogurt.
Okay. How effective is it with heavy bleeding pockets that bleed easily on probing?
My understanding is that it is very effective with these. It is a very powerful hemostatic agent, so it will be very helpful in these situations.
Someone asked, what about calcium hydroxide that makes HYBENX not possible to use? Can you talk about that a bit?
Yeah, I can, for sure. Basically, when you have a concentrated acid and calcium hydroxide is an alkaline substance, what happens is when the two are used in large quantities together, what can happen is an exothermic reaction can occur. So in this hypothetical situation where there could be exposed calcium hydroxide, this is more for a dentist doing an RCT therapy. They really need to choose one or the other. They shouldn't be combining those two therapies together due to the exothermic reaction.
Okay. If it helps ulcers, what about cold sores?
I think I've got to double check on that because the ulcer, it may help with it a little bit, but HYBENX does not work strongly on any sort of keratinized tissue. It's really designed, the exact the chemistry of it is for mucosa. So it works well in the mucosal environment, but around a keratinized environment like your lips, it may not work as well. So it would kind of depend. I'm not 100% sure on its effect on cold sores, but you know what? We can have that in some FAQs that we put on our website.
Okay. If you recommend the gel more, when would the liquid version come in handy?
Liquid version comes in handy, obviously in applications that dentists would use, probably like things like getting it into a root canal and things like that. And also I've heard from clinicians using it for periodontitis is that they sometimes like to use the gel for the super G applications, and then they use the liquid for the sub G applications because they feel it really flows well in there. Other clinicians prefer to use the gel both in the super G and sub G applications.
Okay. I think you've already answered this, but is this something that needs to be applied at each visit or something that the patients slowly wean away from and eventually not need?
Yeah, I mean, ideally, like I said, if you have a patient that has good health, you're able to retrain them to have good oral hygiene. This could be a one-time reset for that dysbiotic film, especially because we know that if there was red complex bacteria in there, it seems to take a long time for them to actually repopulate and colonize a pocket so that it's causing destruction again. However, in your patients that are exhibiting either poor oral self-care, or maybe they have complex health, it's compromised in some sort of way, their host response may not be as powerful. Maybe this is an environment where those pathogenic species are going to thrive more quickly. Certainly, I know from that RCT that the patients they selected, they were patients with chronic periodontitis, but they didn't really have any other exacerbating health conditions. So it is possible that in patients that have more compromised health, that maybe that red complex bacteria would return more quickly.
And that sort of leads us into the next question. Is there a time limit between applications?
No, in general, actually, there's not. Again, it's a localized therapy. It's just a desiccant. So there's no limitation to say you can only apply it once every 6 months, or you can only apply it 4 times a year. You can honestly select how and when it's used, because it is such a localized treatment, and it's such it's a chemical treatment, but it's really like simplistic. We're not working with any thing complex. We're just sucking water out of something. So there's no specific limitations. You can use it as frequently as necessary.
Okay, and someone would like to know, would this be an alternative to LAPT treatment?
Oh, you mean lasers, right?
Yeah.
Yes, yeah. I think that they could be considered as an alternative to lasers. So lasers are obviously a very, very strong way to actually remove biofilm. I would think that using the two together would be possibly overkill. I think that could. So I'm not a laser specialist, so I won't delve too much into that, but that's certainly in discussions with people that are more specialized in lasers. They've told me I think it would be overkill to do both. It could consider using either laser therapy or HYBENX therapy. They could be alternative ways to provide a very similar treatment.
Okay, and someone wants to know about difficult to access areas like furcations. What's the risk if you can't remove all of the treatment from the pocket?
Well, first of all, you should be able to remove it because it's nice and viscous. I would actually advise, this is what I thought to myself, I'm like, you know what I would do if I was applying it into a deep periodontal pocket? I would start with my HVE, my triplex syringe. I would rinse, 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 and then I would grab my my ultrasonic. I would put it onto lavage only, so it's only water, no vibration. And in I would go in with my ultrasonic, and I would take some time, probably a minute, to do a thorough rinse. In the hypothetical situation that somehow you were unable to remove all of it, basically HYBENX has a self-limiting factor. Once it's fully absorbed water, it won't absorb water anymore. And that's going to be self-limited. If it was, say, hypothetically super diluted, some weird situation happened where it was stuck somewhere and you couldn't, if it was super diluted, it might cause some irritation to the soft tissues. We really, really do want to remove all of it. So that's what I would suggest, is doing that thorough rinsing, which is very easy in the Super G. And then for the Sub G, get in there and lavage with your ultrasonic on that 0 power setting so that you can know that you fully removed the HYBENX. And it does come out easier because remember, with coming to from room temperature to body temperature, it becomes less viscous and it is easy to remove.
Mm-hmm. Okay. You've answered this one as well, but how does HYBENX taste? Does it help with malodor?
The taste is sour. A lot of products that are acids have basically a sour taste, and this is no different. People have told me it's not like awful, but it's not pleasant exactly. So it's not pleasant to taste. And would it help with malodor? Only in so far as when you remove a dysbiotic biofilm, oftentimes they are actually going to be releasing those dysbiotic biofilms. They do release compounds that can contribute to malodor. So by removing them, I would say, hypothetically speaking, it could probably help with it if the cause of the malodor is that dysbiotic biofilm in the pockets.
Right. Okay. I'm not sure if you know the answer. How long were the clinical trials and tests, and how long has it been actively used in the market?
Okay, in the EU, it's been used for 5 years. It has been approved by their equivalent of Health Canada. In Health Canada, it was approved actually several years ago, and we've just starting to use it. Oral Science launched it just in January. In the States, it has been approved by the FDA in 2021, and it has been used there for about 1.5 years so far. With Health Canada, HYBENX is classified as a class 1 device, which means it's in the same category as other devices like a thermometer. It's not considered a drug, it's considered a device, and it's actually at the lowest level, so it's considered a very safe thing to apply.
And that leads us into the next question about whether it requires a prescription from a dentist in BC.
Not that I'm aware of. Because we are using a device, there's no need for a prescription for a device to the best of my knowledge. So we can able to use this because it's not classified as a drug.
Okay, can you charge for this service?
Yeah, you can. And this is really going to vary province by province, but you're going to have to take a look into your fee guides. It'll be something along the lines of a chemotherapeutic irrigant, an antimicrobial irrigant, something of that sort of code. There are codes associated with those, usually in the periodontal side of your fee guide. So I really can't comment too much province to province, but there's definitely codes that can be charged for the service. In my province of British Columbia, it looks like that's, gosh, I'm trying to remember no, it's not coming to me. I don't remember the actual code, sorry.
Okay, I know in Ontario, it's usually 43511, 43521, any of those chemotherapeutics, but check with your caller. There's quite a number of questions and we're past the mark. So we're gonna make sure we answer all these questions. We'll send you an email with an answer to your questions if we didn't get to them. A lot of them are repeat questions, but one of them is, will this presentation be available to view? And yes, it will be available on the Oral Science website. Correct? Martha, yeah. And they're asking you, okay. And they're asking if it's available, a printed version of it.
I don't know that we are going to have a printed version, but please come and visit the Oral Science website. Head to the professional side of Oral Science. If you just type in your search bar, Oral Science HYBENX, your first hit will probably be us. It'll take you to the website. You're going to be able to see more descriptions of the product that are written. You're also going to see some videos. There's some videos from its application in non-surgical therapy. Also, they have videos there that show surgical periodontal therapies like flaps. There's also around implants that we didn't even get into it today, but there's the whole aspect of how to use this around peri-implantitis and perimucositis. So that's definitely another use for it, another webinar that we can have. And also, if you scroll all the way to the bottom of that page, you'll see that there's a link and it shows you something, a company called Epien. And Epien is the parent company of HYBENX. They're located in the United States, and it'll take you to their website. If you're looking for a lot of science, like you're like, I would like to take a look at the studies, that's where you want to go. You're going to find all that information there. But ultimately, hit that QR code and we'd love to come to visit you at your office and give you more information about this amazing product.
That's great. Well, thank you everybody for joining us. Martha, thank you for this incredible presentation. And
I think this is going to be the tip of the iceberg of something very new and revolutionary for dental hygiene.
Absolutely. Okay, well, we wish everybody a really great night and thank you so much for joining us.
Yes, good night, everyone. Thank you.
Bye.